Yeah. After, I think we need to move on. It's my pleasure, Dr. Shaheen there, to invite Dr. Shaheen Walidina for the difficult talk of how to optimize the medical management. Dr. Shaheen Walidina leads the pediatric pulmonary hypertension services in UK, and he also leads the part of the team of pulmonary hypertension at the Great Ormond Street in UK. So over to Dr. Shaheen, please. Also, he's up early morning for us. It's 5 a.m. there. Thank you so much, Shaheen, and please over to you. Thank you.
Thank you very much indeed for the gracious invitation to join you. I'm just going to try and share my screen. The previous speakers have really nicely highlighted the issues, and so some of this will be recapping. I'm going to try and talk to you about risk stratification and optimization of medical management. It's quite a big topic, so I think I'll go through it relatively quickly, and perhaps some things can come out in the discussion. And what I'd really like to talk to you about is, well, briefly, why to risk stratify, but we won't spend too much time on that. And then I'd like to think about risk stratification as looking at the disease, and I think Dr. Maron had a very nice slide about this, in multi-dimensions or multiple domains. So the vasculature, the physiology, the right heart, and the entire organism, and how it affects someone across the entire domain. I'll show you some modalities to assess these domains, but I think this is modality agnostic. So we can use whichever modality is available and routinely used. The main thing is focusing on the domains. And the reason I think that it might turn out to be important is because it will allow more targeting of treatment to the area that's causing that specific patient the problem, and also lead to a better understanding of pulmonary hypertension. So this is just why there's a problem. I think we know this, that the survival is terrible without treatment. This is historic survival. And now, in theory, the treatment strategies are very complex. This is a treatment algorithm. So you have to navigate your way around this treatment algorithm. And in order to do this, it's predicated on your level of risk. So risk stratification helps you navigate. But that's the very parochial reason to stratify. The other reason is to really, it gives you a much deeper understanding of what's happening in that specific patient. Now, pediatric pulmonary hypertension is quite heterogeneous. This is PAH in our cohort. And even within the congenital heart disease cohort, which is quite the majority, there's quite a lot of heterogeneity. And, when we're thinking about risk, we're talking about the risk of outcome, and we can see that the cause of pulmonary hypertension is a major factor in how one does this. Is work first published by Professor Howarth, who established a service showing differences in outcome with different causes of pulmonary hypertension. So everything starts from the cause, and pulmonary vascular disease starts from the vasculature. This is our interim analysis. The slide's a bit busy, but basically what it shows is each of these circles is a different classification of pulmonary hypertension. We can see that actually a lot of children, about 25% of children, have overlapping causes of their pulmonary hypertension. And in order to prognosticate, one needs to know what the cause of the pulmonary hypertension was. Okay, so although the pulmonary hypertension starts in the vasculature, we get physiological changes. I think Dr. Maron showed this slide well. So we conceptualized increasing pulmonary vascular disease and worsening clinical status. And indeed, this is a beautiful paper I can recommend to anyone. It's a lot of work by someone called Mark-Jan Plogestra from Holland, who did a systematic review of outcome variables in pediatric pulmonary hypertension. And he showed, yes, pulmonary vascular resistance, the hallmark measurement of pulmonary vascular involvement, does predict outcome across a range of studies. So we looked in our cohort. This is our cohort, and this is a graph to recapitulate that conceptual chart that we saw earlier, with the resistance increasing on the right and the pressure increasing on the y-axis. And, you know, if the pulmonary vascular resistance was the only determinant, the sole determinant of pulmonary outcome, you'd expect the patients on the far top right to die first, and then slowly patients with lower and lower resistances. So we looked at our cohort. These are all the patients. And after 1 year, 2 years, and 3 years, you can see the red dots are the patients who didn't survive. And you can see that they're actually scattered across the entire chart. So resistance is not the sole determinant of outcome in these patients. But resistance is a static measure. And some patients respond to therapy, so we should take that into account. And of course, acute vasoresponsiveness is a rare but significant predictor of outcome. So dynamic measurements, this is an acute dynamic measurement. The other very important dynamic measurement is over time. How does your resistance change over time? So in order to explore that further, people have looked to see what beyond vascular resistance, but still in the vasculature, still in the domain of the vasculature, what beyond vascular resistance might determine outcome. And, you know, pulmonary vasculature is compliant, and the flow is pulsatile. So people have looked at compliance, and in fact, the compliance of the vasculature does also predict outcome. But again, it doesn't tell you everything about outcome. So if it's not just the vasculature, what's downstream of the vasculature? And you can think, well, it's the cardiac response to afterload. And again, for Mark Yan's paper, he looked at a number of parameters from the published literature, all of which measure by some means cardiac response to afterload. So either right atrial pressure, cardiac index, or N-terminal proBNP. And all of them show prognostic significance. In our center, we tend to use a lot of MRI, so I'll show you some MRI data. So this is awake MRI, and we also confirmed, if it needed confirming, that cardiac remodeling and cardiac dysfunction predicts outcome in patients with pulmonary hypertension. And cardiac remodeling and dysfunction includes valvar dysfunction. Okay, so we can see that the degree of vascular involvement predicts outcome, but is not the sole determinant of outcome. Its effect on the heart predicts outcome, but that's not the sole determinant of outcome. In turn, the cardiovascular response to some extent affects the organism, the human, the child, and the top manifestation typically in pulmonary hypertension is exercise limitation. So does exercise limitation predict outcome? And indeed, in a number of studies, measures of exercise intolerance do predict outcome. Interestingly, in children, 6-minute walk test is very variable. In some studies it does, in some studies it doesn't. And I think in Mark Yan's systematic analysis, it wasn't a consistent finding. We did some work with cardiopulmonary exercise testing, and both peak oxygen consumption and also ventilatory efficiency did robustly predict outcome. So going beyond exercise capacity, one of the main systematic or systemic manifestations of illness in children is growth failure. And one can expect a significant chronic disease to impact growth. And indeed, both we on the right and Mark Yan, using data from the TOP registry and the French registry, showed that growth failure measured by weight and height Z scores are prevalent in children with pulmonary hypertension, and Mark Yan showed that they correlate with other measures of thought to be related to poor outcome, and in our smaller study we showed that actually it predicts outcome. So those are, you know, objective measures of how a patient is affected by vascular disease, but there are also subjective measures, and functional class is the most widely used and robust measure. And although it seems very subjective, it is very robust in predicting outcome. And this is data from our center, but this is universal in every study that's been published, that functional class robustly predicts outcome, and it's can be done even by the patient themselves. We took this a little further, and we use a generic quality of life score called PEDQL. It's a 10 question quality of life score, and again, unsurprisingly, quality of life was reduced in children with pulmonary hypertension, but the score in the physical domain, so the quality of life score is split into a physical and psychological domain, the score in the physical domain correlated with survival. Okay, so just going on to treatments. So we can see how each domain that the disease affects, vessel, heart, exercise physiology, entire organism, psychology, all inform the patient's experience of pulmonary hypertension, but also outcome. I'll quickly show you some data, and then we can maybe discuss some reasons why untangling the cause of that specific patient's problems might help target therapy. Now, most of the trial data has already been shown beautifully by Dr. Maron. This is a really nice, I can highly recommend this paper. This is a really nice network meta-analysis published in 2017 of all the randomized controlled trials published to that date, and comparing all of them to see which combinations or which monotherapies are most effective. And so here, this is effectiveness in improving functional status as a risk ratio. And the way you read this is you compare so you compare one with its correlate, the other. So in this case, endothelin receptor antagonist versus prostanoids, parenteral prostanoids, and effectively parenteral prostanoids are 3 times better than ERAs at improving functional status, as a combined pooled analysis from a number of randomized controlled trials. In fact, there's a lot of data in the chart, but the bottom line is, unfortunately, parenteral prostanoids, of the therapies which are available at the moment, parenteral prostanoids have the greatest effect in improving functional status. And then if we look at the opposite question, which is how well can we prevent worsening rather than how much can we improve the patient, combination therapy. So in this study, endothelin receptor antagonist and PD5 was better than single therapy. I'd note that there's no combination therapy assessed for prostanoids in this study. So prostanoids for controlling the vascular disease had the greatest effect in improving patients, and combination therapy the greatest effect in preventing worsening. We also, there are other ways you can use therapies. We did a little study looking at changing within class, so patients who are already on one ERA and a PD5, so Vasentan and sildenafil, swapping them to an alternative of ambrisentan and tadalafil. This is in children. And what we showed is the swap was tolerated. There was no improvement in, there was no worsening and no improvement in a wide range of measurements, although functional class did improve slightly, but statistically significantly. Okay, there's a talk on Potshot later, and it has been mentioned, but the reason I bring it up here is these are the data from International Potshot Registries. This is to highlight treating the right treatment for the right problem. And so Potshot is looks like a very promising treatment for helping RV dysfunction and improving survival in patients with significant pulmonary hypertension, suprasystemic pulmonary hypertension. But you can see that a significant proportion of patients didn't do well. And we think it's likely that patients who have very significant RV dysfunction, this is not the right therapy for them. So looking at the RV function domain in our risk stratification would tell us that this is not the right therapy for patients with decompensated right ventricular function. And then just to finish up, this is a case report of 2 patients that we've looked after who had severe pulmonary hypertension after arterial switch operation for a neonatal arterial switch operation for TGA, and they had progressive worsening in symptoms and in BNP and dilating right ventricles with failing function. And actually the problem with these patients was that they were developing worsening neopulmonary valve regurgitation. And when we did a catheter, the actual pulmonary vascular resistance was unchanged, it hadn't worsened. And so the right treatment for them was not more pulmonary vasodilator therapy, it was to restore valve competence. And we replaced their pulmonary valves, and you can see that the right heart shrank in size, the ejection fraction improved, and the patients improved clinically. Okay, so to conclude, risk stratification and domain-specific risk stratification aids with complex decisions. It gives you insight into the disease in that specific patient and helps you phenotype the problem in that patient and then therefore tailor the treatment. And I thank you all for your attention.
Thank you, Shaheen, for that wonderful, insightful and exhaustive lecture. Just one quick comment on, most of the trials are about 16 weeks, 6-minute walk test, etc., etc. There are not very many outcome analysis data. My worry is, which I often wonder, is there a possibility of tachyphylaxis with these drugs? Especially ERA, do they have tachyphylaxis over a use of, say, maybe a year or 2? Do you any foresee such a problem that they might lose their effects, which happens with almost all the drugs?
Yeah, I think that's a wonderful question. I don't know that I have any specific insight other than to say that I think the paradigm which we all work in is that the disease is progressive.
Yeah.
And it may not be tachyphylaxis in the sense of, in the clinical pharmacological sense, that the target engagement and the receptor blocking is less effective. Rather, it may just be the progressive nature of the disease. For ERAs and PD5s, I think for prostacyclins, there is clear evidence of tachyphylaxis.
Yeah.
But you can counter that by increasing doses of prostacyclins.
Right, because that would have bearing on whether you start upfront too or you wait for the worsening, in Indian settings. In any case, thank you very much for your comments. Any other questions? If there are none, then I would request Dr. Guleria for his closing comments. If he's there, I think we probably have to leave for some meeting. So, any other comments, Dr. KK?
I think we should wind up in the interest of time because we are 5 minutes beyond, but it is a wonderful session and I think it was excellent talks, all of which were deeply insightful.
Thank you. Thank you.